Good afternoon, everyone, and thanks so much for joining today's Breathing Policy Forum. My name is George Habib, and I'm the President and CEO of the Lung Health Foundation. We began the Breathing Policy Series Forum 3 years ago because we saw the many gaps and challenges facing our healthcare system that needed to be addressed. And in addressing gaps and inequities is key to our mission. These forums have allowed us to bring together different health experts and thought leaders from across the country to facilitate discussions on some of the most urgent issues facing healthcare today. Today is the last of a 3-part series focused on COVID-19, marking an exciting new partnership between the Lung Health Foundation and the McMaster University's Global Nexus for Pandemics and Biological Threats. This partnership has allowed us to provide Canadians with evidence-based timely information on COVID-19 vaccine efficacy, infectious respiratory diseases, and other public health measures put in place to manage risk and improve people's lives. In addition to this, we're collaborating to advance policy recommendations and solutions to decision makers for some of the major issues associated with COVID-19. In today's discussion, panelists will deliberate on Canada's vaccine performance from manufacturing to rollout. We know that Canada's path towards vaccinating the population has been anything but smooth. Canadians were disappointed to know that Canada lacked the domestic manufacturing capacity to produce vaccines and would have to rely on foreign sources to attain doses. While the pace of vaccination significantly increased, our vaccine rollout was slow to pick up in the beginning of the global vaccination campaign. Communication from various levels of government was inconsistent and constantly changing, which created confusion and mistrust among the population. Today's conversation will touch on all of these topics as panelists reflect on the lessons learned and the challenges that will need to be faced ahead. Before I turn it over to our moderator, I'd like to thank our 2 panelists, Dr. Zane Chagla and Dr. Matthew Miller, for joining us today. It's wonderful to have these 2 McMaster infectious disease and immunology experts with us today who are leading the way in Canada's COVID-19 research and evidence response. Now, without further ado, it's my pleasure to introduce today's moderator, Heather Backen. Heather is the publisher and Vice President of Business Development at the iPolitics and Queen's Park Briefing. She currently serves as the President of World Press Freedom Canada, the past President for the Canadian Club of Ottawa, and founding President of the Ottawa Debating Society. Heather is a graduate of Ryerson University and received her certification in digital communications management strategy from the University of Toronto. Prior to joining iPolitics, she taught media law at Algonquin College and was a broadcast journalist with CBC News. Please help me welcome Heather Backen. Heather?
Hello, George. Thank you very much. I really appreciate that fabulous introduction. And now it's my pleasure to introduce the 2 panelists today with a little bit more background information so you understand the authority that they bring to the discussion. Dr. Matthew Miller is an associate professor in the Department of Biochemistry and Biomedical Sciences at McMaster University. He is also a member of the Institute for Infectious Diseases Research and the McMaster Immunology Research Center. During his time in New York, Dr. Miller's research focused on characterizing the innate and adaptive immune responses to viral infection. Specifically, his work helped to define how broadly neutralizing antibodies against influenza A virus are generated and function in humans. He also discovered an unexpected role for synataxin, a protein involved in several neurodegenerative disorders, including ALS, in regulating the antiviral response. Dr. Miller is the lead author of the study on neutrophil extracellular traps, also known as NETs, that have been found to be capable of neutralizing the COVID-19 virus. And he was also one of the researchers at McMaster University who developed a new vaccine called the nanoparticle vaccine that could make seasonal flu shots more effective. Our other panelist today is Dr. Zain Chagla. Dr. Chagla is an associate professor at McMaster University, co-medical director of infection control at St. Joseph's Healthcare in Hamilton, and a consultant in infection control at the Woodstock General Hospital. Dr. Chagla is also a teacher at McMaster University, where he won a Clinician Teaching Award in Internal Medicine and a Young Investigator Grant for his work in supporting undergraduate medical education at the University of Namibia. As an infectious disease specialist, Dr. Chagla has given media interviews on the COVID-19 pandemic and published several op-eds on testing, disease elimination, and public health interventions. During the COVID-19 crisis, Dr. Chagla has contributed to local, provincial, and federal policy planning and to several clinical trials on COVID-19 therapies. He has published works on COVID-19 research, epidemiology, testing, and infection control. So with these bona fides, let's move on to our discussion. Let's start with manufacturing capacity. By the way, I'm just going to refer to these esteemed professionals by their first name to let everybody feel as though we're just having a conversation. So Matthew, let's start with you. Why did Canada lack the capacity to produce vaccines domestically?
Well, I think it was really a multifactorial problem. One of the problems was that we lacked flexible, large-scale manufacturing sites. The flexibility is important, obviously, because in the context of a pandemic, you never know which company is going to end up, developing the successful vaccine. So in Canada, we already have substantial manufacturing facilities for vaccines for some major pharmaceutical players like Sanofi Pasteur and GSK. However, as most people probably know, those weren't the companies who ultimately had COVID vaccines move through emergency use approval first. So we really need to have another set of facilities that are capable to scale manufacturing of diverse types of vaccines that could be done on license from diverse companies. And that was a real limitation going into this pandemic that prevented us from even having the opportunity to license and produce some of these vaccines domestically. And so this is an area that definitely has come to light as a priority for Canada moving forward.
So the government recently launched the Biomanufacturing Life Sciences Strategy in order to strengthen the life sciences sector. And also part of that was to improve economic growth in the sector and ensure pandemic readiness, speaking to the point that you just touched on. What are your thoughts on this strategy? How have they done on that front?
Well, I think the strategy sounds good on paper, and time will tell how well it's executed. In many ways, the bricks and mortar piece of this strategy, which is building, facilities capable of to scale manufacturing, is the easy part. What we really need is sustained investment throughout the vaccine discovery and development pipeline. So that starts with investment in basic research at universities, support that flows through that into our biotechnology sector for emerging young biotechnology companies that are developing new and exciting vaccine technologies, all the way through to clinical trial testing, which most people would consider sort of mid-scale, and then to large-scale population-level vaccine manufacturing. One of the tricky things about ensuring that we have domestic capacity is being forward-thinking about how we procure that domestic capacity. Because as I said, it's very difficult in advance of a public health emergency to predict which company or companies may be, first and successful in having a successful vaccine approved. So we need to think carefully about, how will we license these things? What will be our strategies for maintaining relationships with these companies to support them and to ensure that we're able to have domestic production capacity and not have these facilities sit empty? And then perhaps even more importantly, our best defense against being in the same position again is to have made in Canada solutions. And so by providing support for researchers and biotech companies who are at early stages and advancing our own domestic capacity to produce made-in-house vaccines, that's really the best way to ensure that we're well positioned in the future, I think.
And is that solely in the under the federal purview? Or are you also talking about provincial?
No, I absolutely think that provinces have an important role to play in this too. We've seen major investments from the government of Saskatchewan, for example, in BIDO, their facility associated or affiliated with University of Saskatchewan. And during this pandemic, the government of Ontario has also provided rapid response funds for COVID-19. We need these to be sustained, though, and proactive instead of reactionary, because it's very hard to fix a problem after the problems emerge. What we need to do is be prepared before these problems happen so that we can prevent them.
So it's really emergency preparedness.
Absolutely. And all provinces have envelopes of budget dedicated to science and innovation, and continuing to support those budgets with greater investment is going to be essential to supplementing the programs run and agencies run by the federal government.
Are there any other policies that would encourage domestic production campaigns that you can think of?
Well, I think that, there's been a lot of talk throughout the pandemic about intellectual property and whether or not it makes sense to waive intellectual property rights around vaccines in the context of emergencies. Certainly anything that decreases the red tape needed to, rapidly and flexibly produce vaccines when the whole global population is awaiting these is a good thing. At the same time, we need to respect the fact that companies invest, large amounts of money in generating these vaccines. And so there has to be a balance to ensure that, companies are able to be profitable. They are companies after all, but that, we balance profits with the imperative of achieving global equity and the ability to roll out vaccines, rapidly when needed.
So in other words, it's in everybody's interest, regardless
of
the business model. Yeah.
Exactly.
Okay, so when we move on to this, you were talking about being fast and flexible, a little bit nimble. So that involves the approval process, which typically can have an expanded timeline, and sometimes those have to be compressed. Zane, I'd like to bring you in on this. When we reflect on Health Canada's approvals for the COVID-19 vaccines, how would you rate them in terms of that timeliness and also efficiency?
Yeah, I mean, the job given to Health Canada at the approval process here was a fairly large role, right? This is not a vaccine that was going to be used in a small number of high-risk individuals. This was a vaccine that eventually every individual who would be eligible would be offered, people over a particular age would be offered, despite, their medical histories, despite the heterogeneity of the number of people out there, despite some groups in the clinical trials that were, not represented within clinical trials, like pregnant women and children, those with, autoimmune diseases. And so, I think Health Canada had a large task to really get through this and obviously surmounting global pressure in order to bring a vaccine to the market for mass administration, such that, that an effective intervention could be used in this pandemic to really prevent COVID-19, which we didn't have. I think Health Canada bridged the gap for the most part. They were able to take EUAs and applications. They were, relatively transparent with their actions. They put out, pretty reasonable cautions. They allowed for a lot of flexibility amongst them. And I think we were one of the first countries to approve the Pfizer vaccine. We were, not that far off in terms of one of the first countries to approve the Moderna vaccine. We approved the AstraZeneca vaccine, despite some places in the world not. And it really did help with our vaccine rollout and campaign. And there was some thoughtful discussions around vaccinations, particularly approvals in 12 to 15-year-olds for the Pfizer and eventually Moderna vaccine. So, it was an incredible task, and Dr. Sharma and her group really did try to do a good job staying real time, not necessarily using administrative hurdles and barriers in terms of getting these vaccines to market, while still going through a thorough review. And the ongoing surveillance from Health Canada from real world implementation, which identified issues like the clotting issue associated with the AstraZeneca vaccine, like myocarditis associated with the Pfizer and Moderna vaccines. Again, they were very transparent about they were looking at monitoring systems. They made very reasonable and evidence-based interventions to reduce risk, as well as advise the population and frame it in the context. And again, given the context of global pandemic and large scale transmission as these vaccines were making it through, I think they bridged the gap reasonably in terms of getting these to market and assuring the safety and quality that Health Canada standardization should have.
So you did mention with the AstraZeneca vaccine, for example, there were issues that I believe came out of the UK and also particularly Denmark, and you don't know if, what the samples are and if there's maybe a vulnerability within a certain homogeneous population. On that front, is it better to go it alone on the approval, or do you see any other way they could have approached it from a global perspective to make it even better and quicker, even though we had a pretty good track record?
Yeah, it does come down to the mandate of Health Canada is protecting the health of Canadians, right? And so there does have to be a thorough and independent review process. Unfortunately, we've seen with other medications, and there's an Alzheimer's drug, for example, that was approved in the United States with very little clinical data, and has been a large controversy that was never approved in Canada, because of the fact that there may have been some conflicts and other reasons why that drug was actually approved. And so, you at the end of the day do want to have that independent body that is, at the service of Canadians to be that last stamp. What I would say, though, is that global coordination amongst the EUAs and data sets that the large companies are providing probably does offer some benefit. And similarly, I think from a Canadian standpoint, the Health Canada approval process is robust. It is a team of, immunologists, virologists, physicians, pharmacists, and pharmacokinetic specialists, policy experts. That is a global resource that could also be offered in many other places in the world, especially dealing with a global pandemic, especially dealing with human resource personnel challenges, could have benefited from Health Canada's approach in vaccine approval. And again, using that as a resource. So, I think there is a lesson learned here, especially with vaccine approvals in the midst of a global health crisis, in terms of pooling some of those resources and sharing some of those resources across multiple networks for both efficiency, but also, again, giving a global contribution in terms of drug safety. But at the end of the day, again, Health Canada is liable to Canadians, and again, an independent Canadian review process, though it doesn't necessarily have to be, a start from scratch process, but does have to be given in the Canadian context, is still, reasonable. And we've seen examples in the past, not necessarily with vaccines, where, an independent review process by one health organization doesn't necessarily get to the same recommendations to another health organization.
So if I'm hearing you correctly, then what you're saying is Canada could be a global leader on this, that we don't lower our standards when it comes to approvals for Canadians, but we can then share the data, the research, the recommendations with other countries to support their initiatives to get things approved.
Yeah, and again, we have 5 or 6 very large drug administration agencies and medication approval agencies in the FDA, the EMA, the UK's program, and Health Canada, and again, in smaller countries and in settings where the administrative delays to getting through a vaccine proposal process are there, again, combining some of these resources as part of a secondary independent approval could very well have been used to help with getting some of these vaccines approved in countries, and again, starting the process in terms of a mass vaccine campaign, which has been lost in many places. So, and I think the World Health Organization is trying to fulfill some of that role in terms of a standardization, in terms of an approval process amongst the large vaccines, and creating a global standard in that standpoint. But it took a little bit of time to get there, and unfortunately, there have been consequences of particular governments going at it independently and only approving certain vaccines and not others for the sake of standardization across a global setting.
So we're stronger together, in other words.
Absolutely.
Yeah. Okay, well, on that front, let's move into the rollout. And I know, Matthew, you're a member of NACI. So you have, an interesting take on these things as well. But I would just say, part of this, the rollout was a bit fraught. I mean, it's been a long time, understandable. But why did Canadian provinces and territories fall short in their rollout processes? If there's anything that you could identify would be where they should at least start in improving things.
Yeah, I mean, I think really all of this boils down to the fact that I don't think there was an appropriate framework in place for how the federal agencies like NACI or federal advisory groups and provinces should communicate and coordinate in the context of a public health emergency. So just for context, prior to this pandemic, NACI met 3 times a year to evaluate Canada's entire vaccine portfolio. And the reality is, of course, that, normally we're dealing with vaccines that have undergone, long study testing periods through standard timelines of phase 3 clinical trials and approvals, and they're not being rolled out in the context of an emergency, right? We could take, the recent approval of the newest shingles vaccine as one sort of example of how this works. And so the communication issues that came to light during this pandemic between sort of federal recommendations, maybe NACI recommendations in particular, and then how provinces implemented those are also just a reality and symptom of our federal system, where provinces have autonomy over their healthcare delivery options, and the federal government aids in providing regulation or in providing advice. Unlike Health Canada, NACI isn't a regulator. So Health Canada's decision to approve or not approve new drugs or vaccines are binding for all provinces. But the ability to make recommendations on how to use approved drugs or vaccines are at the discretion of provinces. So NACI has served as sort of the brain trust of those recommendations in the past, because it also reduces the strain on provinces to have all of that expertise internally. Of course, during this pandemic, provinces massively increased the number of experts who they have advising on issues from vaccine rollout to COVID-19 policy. And so that was good in some ways, and that it allowed provinces to have more autonomy, but it also in certain cases created the optics of conflict, even in cases where there wasn't really conflict. Some of those were just issues of timing, for example. So to summarize this, I think the real issue is that we need to be prepared and have frameworks for how we deal with public health emergencies before those emergencies happen. Because when the emergency is happening, we're scrambling to deal with the issues and sometimes forget the important pieces of communication. And how we do that during an emergency is very different from how we do that during, sort of ordinary time when there isn't, tremendous time pressure.
So the luxury of time was something that we were bereft of in this pandemic. And it explains, I guess, yesterday, Alberta's chief public health officer came out and had to talk about her communications and that she never intended things to happen. So if I'm hearing you correctly, what you're saying is that the advisory council has very specific expertise attached to it. So the people who are advising or advising on something that they've specialized in, and they would be ostensibly the best and the brightest in the country with that brain trust. And then what I'm hearing on the provincial level, every province is scrambling because it's a patchwork, and you're getting advice from a lot of different people, and they may or may not have the direct appropriate expertise. This is a very human thing. So well-intentioned people don't have enough specialization to give the best advice. They can give good advice, but not the best advice. And then, so is that what you're saying, that they have to be cautious of this? Would a provincial advisory council defeat the purpose of this, or would that create more of a problem?
No, I think that the question of expertise and capacity really varies from province to province. And I think partially this is a reflection of just like total population, right? So there are some provinces that, have really robust provincial immunization advisory committees, and other provinces which just don't have that capacity and therefore rely more passively on NACI advice. What I think is really important, though, is that because because media is by and large national, right? Most people at home are consuming lots of different national media sources, in addition to whatever local or provincial media sources they consume. We have to be really conscious of consistency in messaging. And therefore, to the extent possible, it's essential that these provincial bodies, where they exist, have really good communication with the national bodies to ensure that the messaging to the public is consistent. And the reason that's essential is that these advisory committees are made up of physicians, infectious disease, public health experts, vaccinologists, and not communication specialists. And in non-emergency times, these bodies are esoteric. Most people would have never heard of NACI prior to 18 months ago. And that's probably a good thing, because NACI was designed to provide this really formal technical guidance to chief medical officers of health and provincial immunization committees and other public health experts. And so in a time where this has become, a topic of interest that's really pertinent to the general population, the language we use and the way we communicate recommendations needs to fundamentally change, because the language that experts who deal with these kinds of technical documents on a regular basis perceive and understand that can be very different from the meaning of even a simple word in the way that a layperson would normally interpret that word. It has different meanings that are contextually important.
So is it fair to say that maybe people should think of employing communications specialists for advisory councils, and that, as someone in the media, I've always argued that beats are very important. You need specialists there as well. You need generalists, but you need specialists. So is this something I guess people should be conscious of moving forward?
Absolutely. And I think, the other important consideration is that in the context of NACI, this is a volunteer organization. They're, unlike Health Canada, who are employees of the federal government and public servants. NACI members don't get paid, and they don't even have a true budget or resources to do that. That falls under the sort of umbrella of PHAC, or the Public Health Agency of Canada. And so PHAC, I think, has recognized this need, now in light of what we've experienced during this pandemic. And I'm certain that going forward, there will be a lot more close attention paid to, how we communicate with the public, and how that needs to be different from communications internally with other provincial public health agencies, for example.
Okay, well, interesting here. So as part of the engagement, we have a Q&A. We've asked people to send in questions, and we normally wait till the end, but I think we have a good one right now that just came in. Could the federal government provide an incentive program for provinces to adhere to NACI recommendations?
They certainly could, although I'm not necessarily sure that that would be a good thing. So let me give you an example of why that is. In general, there are very few examples where provincial guidance has been vastly different from NACI guidance. There's been, differences in timing. For example, certain provinces have recently recommended third COVID vaccine doses for immunocompromised populations, and we're awaiting NACI's recommendation on that. But it's very likely that these things will fall in line, that there will be consistency. In other cases, there were slight differences in the way that prioritization happened. The reality, of course, is that Canada is an extremely large, diverse country, and different provinces have slightly different needs. So I do think it's important for provinces to have the autonomy to tailor advice to best suit the realities of their population. And let me give you one very quick, but I think pertinent example of this. When the clotting issue came to light with AstraZeneca, there was a lot of confusion about when is it safe to administer AstraZeneca? Should we be administering AstraZeneca? And the reality was that there was a cost-benefit equation that had to be looked at, which was balancing how much COVID was circulating, how many infections were happening, versus the possibility of adverse events happening with a vaccine. If you were in the Atlantic provinces where there were like no cases, that cost-benefit equation would have strongly argued against using the AstraZeneca vaccine. But if you were in Toronto or Montreal, where there were rampant cases and local community transmission rates, right, that strongly argued for a huge benefit of using the AZ vaccine. And so NACI is very thoughtful about trying to respect the need for there to be provincial flexibility in generating their guidance so that provinces can tailor things but still fall sort of within the general guidelines that NACI recommends usually.
Okay, thank you, Zane. I saw you shaking your head or nodding in approval a few times. I'm just wondering, like, just to pivot off of that, what government should do to safeguard this type of evidence-based approach. So you're looking at the evidence in your region and trying to roll that out in terms of future mass vaccination rollouts. So I think as a layperson, when I hear mass vaccination, I think pan-Canadian.
Yeah, but the reality, and I think Matt alluded to, is we are a completely heterogeneous country, and even a completely heterogeneous province. Even with the we're in Ontario. Ontario, there's a very big difference between the GTA and Kenora, and again, vaccine strategies, mass vaccine strategies do need that local context in terms of resources, at-risk populations, distribution, prevalence. Many other factors that led to, a little bit of this conflict between provincial authorities and NACI's advice. And, again, many, as Matt had said, many of those conflicts were not big on, or they weren't really existentially large in that context. They were largely small issues. They were this prevalence issue with AstraZeneca. It was giving older people the AstraZeneca vaccine while the evidence was still coming out around it, which did show eventually some benefits in that population. It was when to pivot to all mRNA vaccines. It was timing of these vaccines. It was priority groups. But again, there is still that need for the local context, and we do know certain populations where vaccinating them aggressively on schedule and giving them as optimal immunity as possible from an exposure risk standpoint, it was the only choice we had. And I think about some of our remote Indigenous communities, some of our shelters, some of our long-term care facilities where we had no choice. We had to, the vulnerabilities that were in those sectors, made them prioritize themselves higher than everyone else because of the fact of the mass, death and disability that we would prevent by giving the vaccines. And where some of that subtlety was created in terms of, first and second doses and prioritizing at-risk communities versus medical conditions, where, again, that local context likely mattered. And this is where, as much as we want to have a federal framework for a strategy, which NACI provides, you do need those provincial constructs as part of making sure that Charlottetown and PEI is not treated the same as Ontario in terms of its vaccine strategy, as the needs and the implementation plans are going to be very different between those two provinces. And again, some of that was lost in communication. Some of that may have been translated into conflict in the media, whereas again, many of those issues were, I don't think as big as what were provided. But again, it is something to learn from this in terms of how can we make that more seamless? How can we create that flexibility without creating the guise of conflict? And again, resourcing people like NACI, where the evidence is changing, where new data is coming out, to be able to respond, quickly. And this is a group of volunteers that meets regularly, that had very minimal web support, that had minimal communications. They've done a heroic task and a monumental task in all of this, trying to translate information and rapidly respond to a 9-month vaccine campaign that's throwing curveballs left and right. We do know that they're, for them to be a central point of trust and a central point of evidence review in this pandemic and pandemics moving forward, they need to be resourced in order to do that. And again, they need the ability to rapidly respond to evidence changes and then come up with guidance as things change, to then not create those feelings of conflict from local levels.
I mean, this is a really good insight that I think was lost during the crisis days, that it is a language issue, and that it became a trust issue, right? So the conflicting messages caused a lot of people to be alarmist, to not trust any of the information. And that kind of brings me to when you said lost in translation. I think one example of where that's happened and is still current is with herd immunity. Right. So especially with the spread of the Delta variant, we were told that we just needed to get to herd immunity. Here's the percentage we need to get there. And now we're being told we won't get to herd immunity, but there's also a timeline that's not being considered there, right? Like a timeline reality check. Could either of you please set the record straight on herd immunity and what we need to know about it to understand the steps forward and to act accordingly and appropriately?
Yeah, sure. I'm happy to share a couple of thoughts and then pass the floor over to Zane for additional thoughts. I think, the early focus on herd immunity and the messaging about herd immunity to the public was really motivated by a strategy that was centered around trying to depict what the goalposts were for people, right? It was a simple message, and the problem was that it was overly simplistic because the situation changed as variants emerged. The utility of the herd immunity message was that it allowed people to sort of understand what proportion of the population would need to be vaccinated for us to get the pandemic under control at the time that message was being sent. What happened, though, was that herd immunity and that vaccine threshold is determined by the intrinsic infectivity of the pathogen in question. And what we've seen with the emergence of new variants, especially the Delta variant, which is causing essentially almost all infections in the country now, is that it's vastly more transmissible than the earlier variants, which has pushed the herd immunity threshold to basically a point right now that's unattainable, given that we can't vaccinate children under 12 at this point because the vaccines aren't approved. What the more nuanced answer, though, and I understand why we didn't lead with this, or why this wasn't sort of the way that this conversation was framed initially, is that indirect protection offered by vaccines is not binary. It's not all or none, the way that this herd immunity threshold was conveyed. The more people in the population who are vaccinated, the higher the the percentage of protection we give to unvaccinated people. It's not 100%, which is what you're sort of shooting for in a herd immunity situation, but it's still much better. And conceptualizing that is actually quite easy, because basically the more people who you have vaccinated in the population, the more immunity there is, the less susceptible hosts there are for the virus to circulate. And so the less likely it is for an unvaccinated person to encounter an infectious person. So in the same way that for people who get vaccinated, our vaccines might be 90% effective in some cases or 70% effective in other cases, the indirect protection that vaccines offer to unvaccinated people is on a sliding scale as well. And so that's a much more hopeful message. And that's the way we now need to reframe this conversation in light of circulation of the Delta variant. We shouldn't be promoting a defeatist message, which is that, herd immunity is unattainable. What we should be promoting is a message that, look, the higher our rates of vaccination are, the better off all of these unvaccinated people will be. Even if it's not perfect, it continues to improve, and it improves really dramatically at the stage we're at right now, where we have 75% of Canadians with 2 doses, roughly 85% with 1 dose. At this point, like, every extra percentage point has a huge indirect impact on all of these unvaccinated people.
So that we just got another question, and Zane, before I pivot to you, I think you'll be able to do a 2-for-1 on adding your thoughts. Continuing the conversation around communication approaches, should the government public health authorities have changed their communication tactics to tackle vaccine hesitancy? We're just hearing now how they could have done that. What are your suggestions on some key messages we should be focusing on? So we got a great one from Matthew. Zane.
Yeah, no, I think that segues well. And I think to add to this herd immunity discussion, that communication is that, do you have to get to a certain number and it turns off like a light switch? Clearly not, right? And we have to look at historical examples here. We have herd immunity in this country to diseases like measles, like polio, where it took years and years of mass vaccine campaigns, large populations, and still, a measles case can show up in Canada and infect a few people. Polio less likely because the vaccines are so potent. But this to say that a single vaccine on the first try that makes it to market is somehow going to induce herd immunity across an entire population for a pathogen that is actually probably more infectious than most other pathogens, other than chickenpox and measles and some of the higher level pathogens. I think we have to have reasonable expectations. The vaccines have changed the game. Absolutely. There is some shielding of high risk populations with the vaccines. We can even see that in places like the United Kingdom with schools where, vaccinating a lot of the adult population and using control measures in schools have given schools a little bit more advantage this year in the United Kingdom as compared to last year. And so, there is still effects that are felt at a population level from large-scale vaccines on top of the healthcare utilization effects, which are incredibly profound with these vaccines from a personal standpoint, not from a population standpoint, but from an individual standpoint. The risk of hospitalization profoundly changes after getting a vaccine series. And I think those are good themes for, again, vaccine hesitancy, right? The big messages I keep hearing are, the long-term effects of a vaccine. And, I think we didn't do a great job at the beginning really talking about vaccines. And NACI and other organizations have really struggled with adult vaccinations because it's a completely different paradigm altogether, right? It's how do you message to a population? This isn't a normal series vaccine. We've had issues with things like the shingles vaccine, with the HPV vaccine, where it's adults who are at risk that are, then accessing therapy, who have questions, who have concerns about long-term side effects, and again, how to empower those groups to then understand the concept of vaccinology and what that means for their immune system. And again, the long-term side effect question is easy to message. The vaccines are short-lived. In terms of a drug you take like Tylenol every week, or some of the medications you're prescribed for blood pressure, cholesterol, you take that every day, and those are accumulating in your body every day as you take them. Not to say they're not effective, they're completely effective. But a vaccine is given as a very small dose. It's used to boost your immune system, but that's it. That's the effect of the vaccine. And so we expect short-term side effects like, arm pain and fevers and feeling a bit off. But we don't expect long-term side effects, at least out of 4 to 6 weeks, because again, the fact is the vaccine isn't there anymore. It's a short-acting drug. It's out of your system like that. And so, again, all that's left over is the memory of this vaccine in your immune system. And I think, again, that was a message that wasn't translated. People thought of this as gene therapy, and it was something that was going to completely alter your genome, where in the reality of the fact, it is probably much more benign than some of the drugs we take on a day-to-day basis. And certainly some of the drugs that, I administer as a clinician in the hospitals. And I think, again, things like fertility, which did need some time to develop, but again, there's been large misinformation campaigns going in the opposite direction. I think as emerging data has come out and how we communicate about it, one of the common things I hear now from patients is, well, look at what's happening in Israel. They're seeing a lot of breakthrough infections. Therefore, the vaccines are useless. And, why should I subject myself to them? And again, really combating that with, actually good statistical data suggests that these vaccines have changed the game completely, right? They've taken the risk of an 80-year-old to the risk of a 30-year-old with COVID-19, with a single dose of vaccine or a single series of vaccines, so both doses. And again, those messages have been put out through the field, through trusted providers, healthcare providers, public health units, through the Public Health Agency of Canada, but really empowering that, funding that, getting these grassroots people out there, getting into communities where a Zoom call like we're on today is not going to necessarily be the major mode of communication, where it's going to be providers and trusted individuals and cultural leaders. There is so much to say there about that. And I think we're learning now with the last mile strategy of getting our vaccines out there that hesitation and misinformation are the largest two barriers left to try to get more of the population vaccinated. And as much as we talk in public health about that last mile, it is often the most expensive, and it is often the most time-consuming mile from a public health standpoint to get that last few percentages out there. But they're as Dr. Miller had noted, they're going to be the most impactful from a percentage standpoint in terms of what it does for our population and how we live with this virus moving forward.
And also, I think when you say misinformation and hesitancy, if you solve one, you've taken care of a significant amount of the other. And so empowering through education can get rid of the misinformation. And there will always be in any society a small percentage that's going to dig their heels in. And they're the ones who ultimately you're talking about with herd immunity. It will become irrelevant if we get to the point where there's the proper uptake. So just while we're here, there's another variant that we're hearing about, and we had a discussion before, and you really cleared it up for me. And I'm just wondering if the audience would benefit from knowing your take on the Mu variant. So the Mu variant is being reported on, and I think a lot of people are worried that this is going to be the next Delta. You don't see it that way. Why is that?
Yeah, so the Mu variant was described in Colombia, and it has circulated around the world, I think in about 30 or 40 countries. It's actually been in Canada for some time. We noticed it back in July and started showing how Canada has actually been one of the leaders in terms of sequencing, so being able to genetically identify these samples, as well as the UK and the United States. So we knew this was here. I think, again, this is communication, right? The virus is evolving, and with the large scale populations it's hit, we are seeing evolution in real life and what that's meant. We've seen alpha, beta, gamma, delta, the World Health Organization really classifying this and risk stratification. But I think that the big concept that was lost in all of this is more mutations, more changes to the virus don't necessarily reflect catastrophe to the virus, right? There is a right kind of key to the lock that gets a virus to be like Delta, where it's taken over the earth very quickly. And it's not simply that, there's a new mutation X, a new mutation Y, a new mutation Z that gets there. We're obviously worried that there is going to be a mutation that, that does, evade vaccines a bit more, or does have some more pandemic potential. But, everyone we hear about needs to be dealt with and needs to be looked at from that population standpoint. What is it doing? How is it circulating? How is it outcompeting other variants? And what is the large scale implication of this? And at least in Canada and in Ontario, we've been sequencing quite well. Mu showed up in July, probably again through travel. It was about 2% of samples. At peak, it was about 3% of samples, and now it's 0.7% of samples, and shrinking by the day, basically. And so I think we're getting a sense this is not particularly fit. It is there. It does escape immunity a little bit. But in terms of fitness, in terms of its ability to infect people and disperse amongst people, we're not seeing this. But what I will say is, we've heard about two variants over the last 2 weeks in terms of Mu and then the C12 variant out of sub-Saharan Africa. These were variants created in populations with large-scale infection, with poor vaccine uptake, with populations that have major immunosuppressive issues, which probably does contribute to the evolution of the virus. These are false alarms in the context of needing to look at global equity in vaccinations, and our scares about these variants are going to continue along if we're not being serious about a global pandemic strategy and a global vaccine strategy, as you're giving the virus many more chances to adapt to our population by letting it circulate unchecked in populations that are impoverished or in countries that are at low incomes.
That's a perfect segue to my next question. I'm going to aim it at you, Matthew, and that is many developing countries, they've barely started administering first doses. So this is an example, I guess, of that. And so, contrast, when you talk about the inequity, when you contrast to the US, which has just announced they're going to be offering third doses to anyone over 50. My understanding is that they're using some pressure tactics to get India to boost their manufacturing capacity for export sales. But this is in a country that has its own domestic issue with the variants going around, Delta being the one that everybody knows about. So what are the moral implications of global vaccine inequity? And how should governments respond? And also kind of want to know how Canada should as well, right?
Yeah, sure. I'm happy to comment briefly, and then I'll pass the floor over to Zane, because I know he's really an expert in this area and has written very eloquently about it. But I think what is hard for people to grasp at home is that their risk in a pandemic is directly proportional to what's going on globally, not what's going on locally. And so, although, I certainly understand that there is imperative to, have really fast, domestic vaccine rollout and vaccine capacity, Canada, when you look across the globe, we hit it out of the park. For all the criticism of the speed of our vaccine rollout, the only reason that criticism exists is because the US is our next door neighbor, and they were faster than anyone else because Moderna was a US company and they completely monopolized the global supply of Moderna, essentially, until they were able to vaccinate their population. So, the US, putting pressure tactics on India to increase their, international supply is kind of laughable in that way, because, those in glass houses shouldn't throw stones. So the reality is, as Dr. Chagwa very eloquently said before, variants come out of unvaccinated populations. The more unvaccinated people there are in the world, the more infections there will be. And infections in unvaccinated people produce lots and lots of virus. And every single one of those viruses is slightly different. And so that provides a lot of evolutionary flexibility for the virus. It gets to basically play in the population to get better and stronger when it's replicating in people who aren't vaccinated. So at this stage in the pandemic, where we've got, essentially a sufficient supply to provide good protection to healthy adults, we still need to be concerned about our high-risk populations. And we're addressing that now in long-term care and in the immunocompromised with third doses. The imperative and focus really needs to massively be redirected towards protecting the rest of the world, because in protecting the rest of the world, we're really protecting ourselves.
So well said, Zane.
Yeah, and this is, from a selfish standpoint, as we talk about from the evolution of variants, obviously an issue, but I think people have to reflect on what we had to do over the last year to get to this point, and the public health measures in place and how they work in the low income world. Lockdowns when people are living hand to mouth, masking and physical distancing when people are living in accommodations that don't obviously allow for that. Healthcare utilization and testing and tracing when you have no access to testing and tracing. All of those don't work in settings that aren't resourced well, right? And so there is even more of an imperative to vaccinate the world in that sense, because a vaccine, doesn't rely on any of those factors. Once it's given, it works, right? And so, again, from a cost effectiveness standpoint in settings where we have, low income populations, many that live in informal settlements, many that live in areas where public health measures aren't available or are very hard to enforce or really don't have much effect. Vaccines are even more potent as an intervention in those populations. And I think add to that point, there is an imperative not only for us from a health standpoint. These are the countries that supply Canada with goods and services. These are the countries that, we've seen political instability in places like Brazil and Cuba from, vaccine and responses. So there's going to be political implications. There's going to be economic implications for ignoring this pandemic that are going to have domestic implications as part of that, right? So this is not only just a moral prerogative and a health prerogative. This could cause instability in many places, emerging markets. And, similarly, it's hard to justify the gap between high income and low income countries of nearly 55 times the rate of fully vaccinated individuals in the high income world as compared to the low income world, in the context of vaccines being available now for 10 months. To see a divide that's even dividing even more, where a single country now in Israel is now the most vaccinated country on earth because they've now had 25% of the population having a third dose, where again, much of the world has not received a first dose. And again, we do have to think about that global strategy, not only again from a selfish standpoint, but what the implications are going to be for the world moving forward.
So these gaps and inequities are actually creating individual super spreaders in a way.
Plus again, all these other parts, political, financial, economic, health systems, there's lots of implications of these that could very well burn us, not only from a health standpoint, but from an economic standpoint, from political standpoints, from economic outputs in Canada for some of the stuff that we obviously have to import into our country. There's lots of different ways that this could come back to us very, very, very poorly.
So when we talk about the jurisdictional issues that you touched on before, that communities in one place may be different than another, that we have the local, the provincial, the national, now we're looking at global. I just want to close on the final question we have from our audience. When it kind of applies, and maybe it's a little bit out of your expertise, but and somewhat political right now, but I'm going to ask it anyway. Can you comment on vaccine passports, and do they work? If I could hear briefly from each of you, and then we'll have to wrap it up for the day.
Sure. I think vaccine passports have a place. Where they're very, very useful is in battling the complacent population. So a lot of our population under 40 are not vaccine hesitant. They're certainly not anti-vax. They're just kind of lazy in a lot of cases. They consider themselves to be low risk. They might not think that much about how, if they get infected, it puts their community or contact at risk. But if you start to constrain what they can do, the leisurely things that, the sort of under 40 crowd likes to do, like eat at restaurants and go to bars and go to sports games.
The over 40 crowd likes that too, by the way.
Yeah, fair enough. Their age has given them more wisdom, though. So I think that's where it's been very useful. And we've seen that play out. We've seen that when passport policies have been enacted, massive spikes in vaccine uptake. What we have to be careful about is that last mile and the way that passports impact racialized and marginalized populations who are already facing other inequities. So I think passports by and large are good so long as we have ways to ensure that we don't further marginalize people who are already marginalized and at risk.
And that's a big risk. Dane, would you like to close?
Yeah, I mean, absolutely. I mean, I do think passports have a role to play right now at this weird point in the pandemic where we can't vaccinate kids. We still need some control of this virus to not end up like places like Alberta that are seeing health systems collapse. And, I think we need to, really say that there are establishments that have been hit extremely hard in this pandemic, restaurants, bars, gyms, movie theaters, that, really do need the ability to operate in a post-vaccine world, that they've done their due diligence, closing themselves during times of high prevalence and, need the support. And, again, those settings are places where masks and other mitigation techniques don't work because you have to eat and drink. And so, we do have to add this level of safety in them. And right now, vaccines are that. They're more potent than any other public health intervention we have in terms of preventing this virus from spreading. They do need an expiry date, and I think you have to communicate that to the population as we get more control, as health systems get better, as we vaccinate more of the population, absolutely. And I 100% agree with Dr. Miller, is the sense that there are still last mile populations that may not be pushed over by a vaccine passport that we still have to reach with education and to deal with the misinformation. And we have to make sure that that line is drawn really to the non-essential setting. We really do have to keep essential settings for everyone equitably, and certainly settings where other control measures that we've been using for the last 18 months can be used successfully to still keep them safe. So grocery stores and other areas and healthcare settings where, I think we still have to be very equitable to people across the board, no matter what their vaccine status is.
Dr. Zane Chagla, Dr. Matthew Miller, it's been an absolute pleasure. Thank you for this robust conversation, and more importantly, for your thoughtfulness that you've applied. And I would argue that if we continue in this pandemic, you are two phenomenal communicators. You have distilled this in a way that I'm seeing comments. I think it's been really super helpful. So you should be hired as communications experts as well as scientists. On that note, I'm going to throw it over to Dr. Jerry Wright to close the session. And thank you for allowing me to moderate this 3-part series. It's been an absolute pleasure.
Yeah, thank you, Heather. Thanks for the expertly guiding us through this conversation.
So again, let me thank Heather and our two amazing panelists, Dr. Miller and Dr. Chagla. So all I can say is, wow, what an amazing session this was. A fantastic capper to a 3-part series that we've had with the Global Nexus initiative here at McMaster and the Lung Health Foundation. Really, it's what you heard today is really what the Global Nexus initiative is all about. It's not just about science. We're not going to solve all of these problems just with science, but we have to have an entire continuum of making sure that these interventions have impact into society. So we have to understand economics, we have to understand politics, we have to understand equity issues, we have to understand, as we have heard so amazingly well, communication. How do we make sure that the best science, which is just, again, remarkable, the amazing science advances that we have seen during the last 18 months, it's actually mind-boggling. But for them to have an impact, we have to make sure that we get the information out properly and to the right people and to the influencers across the world. And that's really what the Global Nexus Initiative is all about. And so I just want to, again, finish up this series by thanking the Lung Health Foundation for the opportunity to partner with them on this. We look forward to many others in the future. really an opportunity for us to I think, get the message out and work with our decision makers. We're in the middle of an election, and this is a time to start thinking about what kind of leadership do we want, and how important it is to have the right leaders, as we've seen around the world where leadership has failed dramatically. So thank you again, Heather and Zane and Matt. Thank you to all the folks who've listened. Thank you to the Lung Health Foundation. And if for anything else, if you know, the biggest unvaccinated population in Canada right now are children. So if you love your children, get vaccinated. All right. So everyone, have a wonderful day. And again, thanks so much for this series. And take care, everybody.
Stay safe.